Our next speaker is DiAnne Davis. Dr. Davis is a board-certified cosmetic dermatologist specializing in non-invasive facial rejuvenation, skin of color, hair loss, and cosmetic dermatologic surgery. She is an undergraduate of Tuskegee University. Also, she received her master's in cell and molecular biology from Tulane, and then went on to George Washington University School of Medicine for her medical degree. She then was matched to our very own University of Oklahoma dermatology residency program. So we are just so happy of all of the things that she has accomplished in her career. She went on after residency to a fellowship in cosmetic dermatology as well as laser surgery with Dr. Mark B. Taylor at the Gateway Aesthetic Institute and Laser Center in Lake City, Utah. And she's worked with over 70 lasers and has expertise in laser skin resurfacing, body contouring, and laser blepharoplasty. She is currently cosmetic dermatologist at North Dallas Associates. And one thing I'll say, she is a proud native Oklahoma City girl. So we are just so happy that she has come back to talk to us and give us information on her topic, lasers in skin of color. Welcome, Dr. Davis.
Thank you so much, Dr. Allen, and good morning to everyone. It's so exciting to see everyone. I remember as a resident when I was helping Dr. Allen plan the first Skin of Color Symposium. So it's really nice to be back and see everyone. I see a lot of people in the audience. Let's see here. Okay, now you guys can see my slides. And can you guys hear me okay?
All is well.
Okay, great. And so I see even some of my mentors. I see some old attendings that I used to work with back when I was a resident, and even some of the residents who came after I graduated from the program. So it's really good to see everyone. And I hope that everybody enjoys this talk on lasers and skin of color. I've got a couple of screens going, and there are some videos in this talk. So if you happen to see my eyes going back and forth, it's because I want to make sure that you guys can see the videos. Again, as Dr. Allen said, I graduated from the University of Oklahoma residency program. I now practice in private practice in Dallas, Texas, and I am probably doing about 40% medical, 60% cosmetics, and I love utilizing lasers as much as I can. And so I'm going to talk about some different applications that I use lasers for today. These are my disclosures. None of them are relevant to the talk today, but I do have relationships with each of the companies listed. And of course, the professional gap that we're going to be addressing today is that, some physicians or practitioners may not know how to determine the best laser or energy-based device that is best suited for a dermatologic concern for skin of color. And, I think in the last couple of years, for a lot of us, especially who have seen a lot of patients with skin of color, we have been learning and, we have recognition with skin of color, either because we got it from our training or either because we ourselves are skin of color. But for a lot of people and for a lot of our patients, they still receive a lot of misinformation out there. And so as dermatologists, we are these skincare experts. And so I really try to use my platform as a dermatologist, also on social media, but also in clinic to really make sure that I'm giving the best advice to my patients on what can be done on their skin and what cannot. Because I know we have all probably slowly seen in practicing just different complications that can occur based on either the patient's skin type or who might be the operator behind a device. Okay, so these are going to be the learning objectives that I will review, which is going to be describing the different skin types, reviewing indications for lasers and light-based devices. I'll review some treatment considerations for darker skin types. I will also review complications that may occur, demonstrate cases where laser therapy is safely utilized in skin of color, and then just talk about some of my protocols that I also like to do. So these are the facts. So in 2018, the plastic surgery statistics reported that non-Caucasians represented 30% of all patients who received cosmetic procedures. But of course, as we know, and what we're just seeing, with our ever diversifying population, is that by the year 2050, over half of the US population will comprise skin of color. And so this is very important for us to know, because you may see someone that walks into your clinic and you may have an idea of their Fitzpatrick skin type. However, when you start to apply a laser or energy-based device, things can change rather quickly, or when you start to see them in follow-up, you may start to actually see that, okay, maybe this patient does have more skin of color because of how their skin is starting to change and respond to the treatment. So for me, I always try to make sure that I look at every patient, even from the fairest of the fair to maybe the darkest of the Fitzpatrick skin types. I always try to look and see, is there any hint of skin of color in their skin? Because that is definitely going to change how I apply my different laser treatments for whatever their concern is. It's also just important to remember, again, lasers are not going to be for everyone. And so you will have those patients that will come in who will say, okay, I have melasma or I have discoloration and I want the most aggressive treatment you can do. And so also, again, just as we saw with the first talk, setting those realistic expectations, explaining to patients why you're recommending this treatment over another is going to be extremely important, not only to optimize your outcomes, but also to ensure that you have patient compliance so that they don't feel like you're trying to, sell them something else and then they don't want to follow through with either the pre-care or the post-care. So these are just things to think about. Okay. So for the purposes of this talk, in the traditional sense, when we talk about skin of color, it traditionally refers to patients with either an African, Asian, Native American, Middle Eastern, or Hispanic background. And so again, patients in these ethnic groups are going to have richly pigmented skin. They're usually going to be characterized as Fitzpatrick skin types 3 through 6. And they usually are going to have, again, a higher melanocyte count than their fair-skinned individuals. But again, like I said, I almost always will look at a patient and try to assess, do they have skin of color or a hint of skin of color in their background? I have a medical assistant and I did a light laser treatment on her. She came in the very next day and she was almost about as my complexion was. And all of a sudden I said, what did you do? And then I started asking her questions. And that's when I learned that she has Native American ancestry in her background. But I did not really appreciate that just from looking at her. So just by even treating her, I slowly started to have to adjust, just my clinical assessment when I'm, kind of giving patients their consultation to recommend different treatments. So always be mindful and always ask to see patients, ask to see old scars, ask to see if they have a nick, a cut, or a scrape, from elementary school, from childhood or something, so that you can assess how their skin heals, so that way you can come up with the best plan. So again, these are, just the unique characteristics. A lot of us may know this information, but again, as the Fitzpatrick skin types go from the fairest to darkest, again, 1 through 6, there are going to be different changes that you're going to see in the melanosomes, the shape of the melanosomes. This is getting back to that basic science we all had to learn our first year in residency. It's also going to have changes in the thickness or thinness of the elastin and their collagen. You're also going to see, again, a thicker stratum corneum, also preserved elasticity or not. So again, just take it into account from the fairest to the darkest of skin types. You just want to remember that for your skin of color patients, our melanocytes are very sensitive. They're very hyperreactive. And that's usually what I explain to all of my patients, or for any residents that I'm teaching. I always explain that our melanocytes, they just don't like to be irritated in the wrong way. And so that's something you want to take into consideration with any kind of treatment. Also, our fibroblasts are very hyperreactive, as we know, with different healing processes or hypertrophic scarring or even keloids. So again, all of this you want to take into account when you're thinking about putting a laser on any patient for that matter, but especially in skin of color. Okay. So leading indications for lasers or light-based therapy procedures in skin of color are going to range from laser hair removal, acne scars, pigmented lesions, skin tightening, photo rejuvenation. And so I'm going to talk about several of these in the talk today. And I'm going to present these in kind of a problem or case-based presentation, so that way we can kind of walk through the most common things that I'm seeing in clinic. So this starts with problem number 1, which is going to be that patient who comes in with either unwanted hair. Their complaint may be, ingrown hair bumps or bumps in the beard region, or they may even say discoloration. And so again, just kind of talking about some of these actual diagnoses. They may not know that their condition is pseudofolliculitis barbae or hirsutism or whatever, but these are the common complaints that I hear in clinic when patients come to see me. So I will definitely tell you that laser hair removal is probably still one of the #1 cosmetic procedures performed with lasers across the board, especially in terms of what I do on skin of color patients. Things that I'm always considering when they're coming in for laser hair removal is definitely going to be the target chromophore that I'm trying to target, which is going to be the pigment and the bulb of the hair follicle. Also, the color of the hair, because that's going to matter, because again, the laser is going to target that chromophore or pigment, and then also the length of the hair. And so I have a handout that I give to patients to tell them how we're going to prep their skin. Again, the indications for laser hair removal will include unwanted hair, again, hirsutism, of course, with the formal workup to make sure there isn't something else going on. Again, pseudofolliculitis barbae is what I see by far and large, and also hidradenitis suppurativa, which lately we've been getting a lot of information from our colleagues, especially Dr. Jeanette Okoye. She's at Howard University. She talks a lot about laser hair removal indications for her patients with HS, just to help to minimize some of this inflammatory process that starts to stir the pot, if you will. By far and large, I use a 1064 nanometer laser for laser hair removal. You can definitely use the 810 nanometer diode. On the horizon, what we are also seeing is that there are some lasers that are using 2 wavelengths, which include 755 and a 1064 hybrid. There are a couple of companies that are starting to produce these lasers. I did participate in one of the studies, and it did well with skin of color. Again, this is just definitely remembering the settings and everything that you're going to use. So this is a picture that is courtesy of Dr. Brian Beesman. This is, again, what we can really achieve with laser hair removal. I see patients that come in like this gentleman, and again, they may talk about either the hyperpigmentation, the discoloration, or the hair bumps. And so for men, what I usually will try to discuss with them is, in addition to just the medical management of pseudofolliculitis barbae, I will ask them, do you prefer to have a clean cut, shaven look, for the rest of your life? Do you like to kind of alternate between having a beard and not having a beard, in the winter season? Because this will definitely guide my talk on if I may recommend laser hair removal for them. So if I have a gentleman that is like, I don't care if I never grow hair again, I like a clean, nice, shaved look, then of course I will say, then we should really think about the investment of laser hair removal, because it will really help to clear your skin, because again, discoloration and skin of color is going to be extremely important. It will also help to minimize those ingrown hairs. And you see these photos here. I see this often too with my ladies who come in, again, with ingrown hairs, either in combination with acne or without. And so, of course, they want to talk about the discoloration. And so I always explain to them what the process is, what is going on. And again, I really start with medical management. I usually will always have my patients on a good topical regimen. Definitely sunscreen is of utmost importance. I will also usually have them on a topical retinoid or a combo of some sort. And then we start to do laser hair removal. And this is a patient of mine here in Dallas. She is a fitness model, and she, was really concerned about her skin, especially because she's in an industry where she's photographed a lot. So I definitely talked with her about laser hair removal. She was on the fence just based on things she had heard in the past, but this is what we were able to achieve after 5 treatments. And now I actually show a lot of her pictures in my practice to really help patients to understand that it can be done properly and safely, with the right guidance and the right operator. Things that you just want to remember with laser hair removal. I usually will start with low fluences, sometimes between 12 to 14 joules, but definitely with skin of color, it's going to be longer post durations, just so that I can make sure that I'm targeting that chromophore. Epidermal cooling is going to be of key importance when it comes to really any type of laser procedure that you're doing on skin of color. That's because we want to make sure that we're cooling the skin as quickly as we can so that we don't have any complications that happen to our innocent bystanders, which are the melanocytes on the surface of the skin that we don't want to target. So oftentimes people will ask me, do I pre or post treat? I tend to alternate. Sometimes it will depend on the severity of their hyperpigmentation when I first see them during their consultation. But oftentimes I just try to make sure that we're scheduling their treatments during the right time of year. That's also important. And then I will usually just make sure that I have them on at least a good topical retinoid. If I'm concerned about some hyperpigmentation, then I usually may add in, again, a lightening agent somewhere during the course of their treatment. One thing that I have learned, I learned this from my mentor, Dr. Callender. So you can see Dr. Woolery Lloyd also first mentioned her name. I'm I'm mentioning, Dr. Calendar, as soon as I am putting heat on the skin, I am calming it down with a topical steroid. I love triamcinolone, 0.1% ointment. You could also do clobetasol, but I really want to calm down some of that inflammation so I am not harming any of those surrounding melanocytes. You can ask Dr. Allen or even Renee, who is our residency coordinator. After I would laser my underarms in residency, I would go and put some triamcinolone on just because I wanted to minimize any risk of hyperpigmentation. So I use that in my protocols a lot. And then, of course, just maximum compliance with SPF, especially if you're doing laser hair removal on the face. Then we want to talk to your patients about that. Okay, so we're going to move on now to problem number 2, which are going to be benign epidermal lesions. So you may have those patients that are going to come into the clinic and they're going to ask you to remove their moles or their spots, or they're going to ask you, what about these little spots underneath my eyes? And so there's a lot of different ways that we can treat them. Lasers definitely happens to be one in our toolkit that we can definitely utilize. So these are a lot of different treatment options for benign epidermal lesions. There are there's a limited number of reports of cases that have had completely successful treatment with some of these that have actually not harmed the surrounding skin. So of course, when it comes to skin of color, cryosurgery, I tend to not recommend that for benign epidermal lesions because I do not want to leave a ring of hypopigmentation in that area. Sometimes it can be successful if you have a nice targeted applicator that you can put on your cryostat, or you can definitely use a little cotton swab so that you can make sure you place it on the lesion. But again, you have to be careful with pigmentary alterations that can happen. For some of these epidermal lesions, depending on the size, you can excise them. Of course, you have to counsel the patients about scars. Electrodesiccation is definitely a popular treatment. Still probably one of the first things I will use, especially when it comes to small seborrheic keratoses or DPNs or dermatosis papulosis nigra, which tend to be the smaller SKs that we see on the face. You can definitely curettage these lesions. Again, you have to be very considerate of skin of color and the possible risk of post-inflammatory hyperpigmentation. And then there have been some topicals that have come out. I don't know if you guys remember a few years ago, there was the 40% hydrogen peroxide. I think, we thought it was going to be, maybe a game changer, especially with some of these larger seborrheic keratoses lesions, but there were some reports of hypopigmentation. So again, our patients of color in our communities, a clear complexion is what we, value as beauty. And so whenever that is altered, then of course, it may affect a patient and how they feel. So I'm always, again, very conscientious about what's going to happen to their skin after I do any type of treatment. And that's probably the biggest takeaway from this lecture, so that I can make sure that I don't induce possibly any other pigmentary alteration. And then, we have a setback instead of achieving the results we want to achieve. These, again, are just some photos of, showing what can happen with either, cryosurgery or some of the topicals that have been used that would cause, pigmentary alterations. And patients are upset, especially skin of color patients. They will be upset if they have, a large, area of hypopigmentation post-procedure. So again, setting those realistic expectations and knowing when to say no is also very important. But there are times when you can say yes. And so these are a couple of videos. Hopefully they are both playing. So what I like to use if I'm going to go from maybe electrodesiccation to going to laser therapy is I like to use an erbium YAG laser. And yes, this is a 2940 nanometer erbium YAG that I am placing on skin of color. But with particular devices, you can actually place a 2 millimeter spot size directly over the lesion, and you can actually vaporize that entire lesion. And as you can see in the first video, this is actually Dr. Taylor who's lasering this particular lesion, but we make a circle so that we know exactly where we're going to color on the inside, if you will, and we keep that laser beam right over the exact epidermal benign lesion. Sometimes it can take a little bit longer in time as compared to what you might be able to do with your hypercator and electrodesiccation. But what we're aiming for is the picture that you all can see on your right, which is where we basically just go down to that dermal epidermal junction and you just have a nice light pink base. And so now I'm going to show you what that looks like in skin of color. Let me see. There we go. So this is a patient who came in. She had a lot of milial cyst, and she had had several treatments with electrodesiccation, and she wanted something that was going to be a little bit more effective. And so, of course, I had to look at her. I definitely did a couple of test spots behind her ears. That's probably take home point number 2. Whenever you're putting an energy-based device on skin of color, no one is going to fault you for doing test spots and multiple test spots so that you can make sure you have the right settings before you actually put it on their face. So this was her after doing the erbium laser treatment. This is her 5 days post-treatment. And so you can see, I usually tell patients they're going to look like little pimples that you've picked like a teenager. So again, this is maximum sunscreen protection. I just had her use a little bit of a Vanity cream ointment on her skin. Again, Aquaphor or Vaseline you could also use. But of utmost importance, I explained to her, no sun while these areas are healing, because I want to minimize any risk of hyperpigmentation. This was a patient I also treated in Salt Lake City, Utah. So I also had a little bit of the season on my side because we did this treatment during the winter months. And so let me show you some more pictures. This is another picture of her 5 days post-procedure. And you can see it just looks like little excoriated bumps. And then this was her, I think this was about 4 weeks post-procedure. So she actually did really good. She was very happy with this treatment. Thankfully, she did not have a lot of post-inflammatory hyperpigmentation at all. And she really followed my instructions. And so this is a great way where, again, we can utilize a laser for certain treatments on these benign epidermal lesions and achieve great results. I do like to use the 2 millimeter spot size erbium on not only milia, but I like to use it on syringomas. I'll use it on small xanthelasma lesions. And again, some of these might be treated again with your hypercator first, but if you're not achieving as much success, or if there is too much background hyperpigmentation, if you do a test spot lesion, I do like the erbium because it's essentially just going to vaporize that top layer of tissue. And again, as long as you have the patients follow post-care instructions, they do extremely well. Okay, and so this is another schematic of this patient, and I did present this at ASDS, and we did actually publish this in Dermatologic Surgery as well, and she healed very well. So again, we can utilize, more aggressive lasers, if you will, in skin of color, but again, you have to do this safely. This is not something that I would, have a beginner do. This is with a lot of meticulous placement and also a lot of experience. So let's get into problem number 3. So melasma. So melasma could be a whole talk in and of itself. And so we have all seen those patients that are coming to us for discoloration or melasma. Sometimes they know their diagnosis and sometimes they do not. So again, first making sure that the patients understand their diagnosis, that they understand that this is a stubborn form of pigment. That's how I like to describe it, and that it can definitely wax and wane. And so there's going to be different treatment options that we may do, just throughout the months and years, because this is not something that is just going to go away overnight. You definitely want to set those expectations from the beginning. Things that I'm definitely considering is I definitely want to do a thorough assessment. I really want to try to assess, okay, is this melasma and pigment more epidermal? Is it dermal? Is it mixed? I also am definitely talking to them about their recent sun exposure. What have they done in the last 2 months? What are they planning in the next 2 months? Because that's going to be extremely important. And also previous treatments. How many lightening agents they've been on? How many different formulations have they been on? What are they doing right now? Because I am not just managing melasma with lasers. Of course, I'm always combining that with a number of different topical therapies. I tend to mix and match, and I change with the seasons. But just making sure that we've covered all of the bases from a medical standpoint first before we start to talk about aesthetic treatments. With melasma, there are definitely a multitude of lasers that you can use. What I have found that has worked best is definitely the picosecond energy and the picosecond technology. And that's because it's going to deliver very short pulse durations, so I don't have a lot of heating to my surrounding melanocytes, but it's also going to be very effective, especially when you use those 1064 nanometer and 755 nanometer wavelengths. So this is a particular patient that I treated. This is 1 month after one treatment. This is with the 755 picosecond laser. And so again, I usually do topical numbing for about 30 minutes. Again, I'm very cautious on my energy settings. I start very low, and then slowly I will start to crank it up if I need to with each treatment. I usually will tell patients it may take 1 or 2 treatments to achieve these results. This patient was very happy after one. You can see she definitely still has a little bit of hyperpigmentation here on some of the areas, but she was very happy with this. And of course, once we get to this point, I usually will tell them, we're still maintaining with the topical regimen. I tell them it's not a matter of if your melasma will return, it's a matter of when. But if we can kind of stay ahead of the curve and make sure that we're maximizing our therapy, patients can do really good. So this was with a 755 nanometer picosecond, and I usually do that at intervals of 1 month. With the 1064 nanometer wavelength, sometimes I can even do weekly treatments or therapies. So again, I put it on extremely low fluence, and I'm talking about 0.9 joules per centimeter squared. But with a 1064 nanometer, I could actually have the patients come a little bit more frequently. It's a lower fluence, so that way I can do several treatments, and then we can usually get them to achieve a result similar to this as well. And then, of course, we're protecting everything with their topical therapies. I'm also just very conscious about other lasers. I mean, definitely Fraxel or, non-ablative laser therapy can definitely be another option for melasma. Again, you want to make sure that you're doing low density and also low fluences. The thing with melasma is that there's that heat component, as we all know. So whenever I'm talking to patients, I usually will explain to them, again, I like the picosecond technology because it's going to be an extremely short pulse duration, meaning it's not going to be in contact with the chromophore or my melanocytes for a long period of time. So I don't have a lot of heat that's kind of being distributed throughout the tissues. With some of the other lasers that can definitely also treat melasma, I'm just a little bit more hesitant because I don't want to stir the pot with heat. Sometimes some patients or even some of my colleagues will definitely do intense post-light therapy treatments for melasma, and that definitely can work. Again, it's just a matter of not if the pigment is going to come back, it's when. So again, with melasma, it's a very stubborn form of pigment. You really have to set the patient's expectations, but you can definitely achieve great results. So now we're going to move into problem number 4, which is my favorite, which is acne scars. And some of you, probably have your patients that come to you. They, are concerned about their acne scars. They may have been to multiple, different locations before and tried multiple different treatments. So they're coming to you, as an expert to see what can you provide them for their acne scars. So when I talk about acne scars and skin of color, we have to remember that there are not just the ice pick scars or the boxcar scars or the rolling scars, but the other scars that you have in skin of color are going to be post-inflammatory hyperpigmentation, post-inflammatory erythema, or even persistent cystic nodules. So again, I have a lot of patients who will come to me for consultations for scarring. And it can be a number of any of these, and usually it's a combination, okay? And there's just no ifs, ands, or buts about it. Acne scars are extremely hard to treat. Again, because patients usually have different types, it's going to be different in multiple modalities you may have to use. So again, setting those expectations is going to be extremely important. When I'm looking at patients to assess their acne scars, first I'm assessing their acne and of course their past medical history. If they still have active acne, get the acne under control first. That's like number 1. And then, of course, I want to assess their past medical history. Is there a component of PCOS? Is there something else going on? Are they on other medications? Because I just want to make sure that I'm thoroughly thinking about the plan I'm going to put together. I also like to assess the type of scarring that they have. And again, I assess their risk of pigmentary alteration. So I'm always asking about old scars because I want to look at them and see how they heal. So that way I can determine which laser is going to be best. This is just a little bit of a diagram of what I like to use for different scars. Some of these are lasers, some of these are other energy-based devices. This is not, a hard and fast rule, but this is usually how I put my different scars into different categories when I'm thinking about treating them. This is also a paper that was written by Dr. Monica Bowen and Carolyn Jacob. This was in dermatologic surgery, and it also just talks about if they have different types of acne scars, the different treatment modalities you can think about using for your patients. And it's actually a really good paper. Also, my fellowship director, Dr. Mark Taylor, he also did a paper on just looking at different devices used to treat acne scars. So this was also in dermatologic surgery. And there are a host of different lasers mentioned here, 2 of which happen to be my favorite that I'm going to talk about for the purposes of this lecture. And so again, with some of my patients with acne scars, they're coming to me already having seen someone previously where they may have done anywhere from 6 to 8 microneedling treatments. They've had radiofrequency microneedling. They've had, different fillers or injectable agents injected, and just a host of different treatments. And now they're coming to you with several types of acne scars. And hopefully you guys can see this picture, but sometimes it's rolling. Again, sometimes it's those ice pick and boxcar acne scars as well. So for my protocol with acne scars, this was a protocol regimen that was developed by my fellowship director, Dr. Taylor. And that's just because he would see a lot of patients who would come to him wanting something that was a little bit more going to give them bang for their buck, if you will. So if the patients have extremely oily skin, or if they have a lot of pitted acne scars, that already lets us know, okay, this is an extremely oily patient. We will recommend that we put them on oral isotretinoin 2 weeks pre and post treatment. And yes, this is going to be with aggressive laser therapy. And that is because we want to shut down as much oil production as we can so that as they're healing, they're not developing more pimples. One thought is that for extremely oily skin, once they create that acne lesion, as their skin is trying to heal, their pores are producing more oil that starts to create that little crateriform ice pick scar. Hopefully you guys can see my hands. So our thought is that if they're super, super oily, you may want to consider even putting them on something that's really going to shut down some of that oil production before you do your treatment. I'm going to show this in videos, but we actually do tumescent anesthesia with extensive subcision using a device he invented, the Taylor Liberator. And this is really for those rolling acne scars. Because with rolling acne scars, everything is not on an even field. You have hills and valleys because you have scar tissue that is pulling that acne scar down like a pincushion. So the real way to really attack those acne scars is to go underneath the skin. And I'll show you that in a video. Then we usually will do a 20% TCA chemical peel along with either fractionated erbium or fractionated CO2 laser therapy. And yes, this is in Skin of Color. And then oftentimes, depending on the other types of scars, we may do some punch excisions, or we may also add on some topical therapies after, which may include PRP or possibly even polylactic acid, which I will explain. Okay, so here we go. So once we prep and mark the patient, the middle video is showing you tumescent anesthesia on this patient. And again, these are particular patients that have more rolling acne scars. And so when I'm doing my markings, you're seeing the different acne scars so that I can make a roadmap. Because once I start to tumescent their skin, as you're seeing in the video, I'm going to lose that surface topography where I can see where my hills and valleys are. So I create a roadmap, and then I'm doing tumescent anesthesia based on the Klein formula by Dr. Jeffrey Klein, who is a well-known dermatologist who developed the tumescent anesthesia protocol. So once we have the patient completely tumesced, then what I'm also going to do is a 20% TCA chemical peel to their face. The reason I have this circle around my acne markings is because this is where my laser therapy is going to go. However, I don't necessarily want the patient to heal with lasered cheeks and then the rest of their skin is its normal color. So we do a 20% TCA chemical peel, which is considered a medium depth peel. And yes, we do this on Skin of Color, and that is so that we can blend everything together so that they don't heal with just isolated cheeks that have been lasered. Okay, once we have done the tumescent anesthesia, then we have the Taylor Liberator, which is this device here, which is what Dr. Taylor developed. And I make an incision right in that sideburn area with an 11 blade. And then I actually am going to go underneath the skin to release those acne scars. So these videos are actually showing the subcision technique. So this is me doing one on my patient in clinic. I think this one will play too. This one is, some people say it makes them a little bit queasier. But again, I'm really going underneath to break up these acne scars. And you can see in this middle video, some people will have these really tethered down scars. And unless you're doing something underneath the skin, you're never going to be able to really smooth out the entire surface, which is really what the patients are hoping to achieve. I think this is another video that just shows, oh, this one wouldn't play, but we will do it up on the temples as well. Of course, this is where tumescent anesthesia is going to be extremely important because there are vital structures here on the face, and you want to make sure that you have definitely stretched out those acne scars so you create a safe plane to enter into to break up those scar bands. Okay, and then we get into the fun part, which is going to be our lasers in Skin of Color. So this is a particular laser device that we would use. And, oh, I'm so sorry, guys, there we go. I feel like I have two videos going. So this particular laser is a fractionated erbium laser. And so sometimes we call this stacked therapy, where it's fractionated erbium, or we're making small passes over the skin. And with this particular laser, we're actually doing 6 different passes over the cheeks. The nice thing with the erbium is that, again, with this particular technology, it's actually going to deliver short pulse durations, but it's really going to help to create those thermal injury columns so that we can start to stimulate new collagen that's going to be younger, fresher, and tighter. We would definitely use this on Fitzpatrick 5 and 6 skin types. Again, it's just definitely counseling the patients and letting them know that for sure for the first week, they're not going to be leaving the house. They will definitely have to maximize their sun protection and get absolutely no sun on their skin, especially the first 2 weeks healing. But patients do really well with this, especially with the fractionated erbium. Okay. And then this is another laser that I really like. So this is developed, the same company, and this company is out of Slovenia. But this is a 1064 nanometer pico and nanosecond laser technology. So once you start to get into the pico and nanosecond wavelength, you are really starting to create high-powered pulse durations that are extremely short. And if you guys have your volume on, you can hear that it almost sounds like little firecrackers. And so we usually will put cotton balls in all of our ears because it's extremely loud. But this is actually delivering very short pulses of energy, but super high with the 1064 nanometer wavelength to, again, create those micro injury columns so that we can really start to stimulate new collagen and elastin. I really like this particular laser because it's 1064 nanometer. So it's definitely going to be a lot more safer for your skin of color patients. They tend to not have as much downtime, but again, it is not a clean procedure, in terms of it does get a little bit bloody. So again, setting those patients' expectations is going to be of utmost importance. But once they have the tumescent anesthesia, the patients are extremely numb, they're extremely comfortable, and often, like you see this patient here, she's going to sleep. And some of these procedures are seen on fair skin types, but I promise I do have before and afters for skin of color. So a couple of things that I like to take into account is, do I want to apply anything on top? So again, with laser therapy, I'm always thinking about calming down that skin. So this is actually Kenalog 40 that I'm just topically applying to the skin. Again, this patient has these micro injury columns. So now I actually will apply that on and apply some saran wrap. This is, again, just to minimize any risk of hyperpigmentation. And so we just topically apply it to the skin. Sometimes if I don't want to necessarily do this, I can send them home with a little bit of topical triamcinolone ointment that they can mix into their healing ointment to apply. Other, additions that I can add onto this treatment would include PRP. Dr. Willory Lloyd talked about that in her lecture. We topically apply it, and sometimes I will even go back underneath the skin and inject it. And lately, I've also been using polyl lactic acid, which is also a great biostimulator that helps to increase that collagen and elastin production so that I can give the patients the most bang for their buck for acne scars. So let's get into some before and afters. So remember when I talked to you guys about setting those expectations. So this was a young patient of mine, and I remember after we did her procedure, the picture in the top left was one she sent me a couple of days ago. And please just know all of these patients are posted with patients' permission. I do ask that no one take these pictures and post them on the internet or on social media. But after I did her laser procedure, I called Dr. Taylor and I started freaking out. And I was like, oh my gosh, the 20% TCA was way too much. I was like, look at how much she's already hyperpigmenting. I mean, I freaked out in fellowship. And I was like, what did we do? And he was like, she's going to be okay. She's going to be okay. And of course, as she started sending me more pictures, I was like, you're too close to the window. Get away from the window. But slowly, again, with time and patience, you can see this is the transition that this patient went through. And thankfully, she's given me permission. I use her photos a lot, especially when I'm seeing patients with a similar skin type as hers, because I want them to know exactly what they're going through. Like if I don't show patients these pictures, if they go through this procedure, I mean, they will call me every day, just, crying or upset or just not knowing that this is what their skin was going to look like as they're healing. So I definitely make sure that I counsel all of my patients. This patient did really good, and she was very compliant with her regimen. And if patients follow the instructions, they do very well. But I do like to show that this is exactly what a 20% TCA chemical peel would look like with someone of her Fitzpatrick skin type. It did take her about 10 days to peel, so a little bit longer than average. But in the end, you can see she has just a little bit of that erythema or a little bit of hyperpigmentation. But I do have some more before and afters of her where we can see how she did. So these are some of the results that we're getting, again, with our patients with skin of color. So this is, again, a patient that is 1 week out. So not only did we do the full protocol with him, but we also did a lot of little punch excisions. And so that's where a lot of these little erythematous kind of papules that you're seeing in his follow-up are. And so with punch excisions, we would usually do a 1.5 or 2 millimeter punch for some of these kind of more distinct boxcar acne scars. And then we would just put in a 6-0 proline. So we have to let patients know that it will look like a lot of pimples, when they first see us at 1 week out. But again, as long as they follow the protocol, they do well. This is that same patient who I showed you all of her pictures for, and this is her follow-up. This is 3 months out, and she did really good with her procedure and was happy with the results that she achieved. This is an example of a Hispanic patient with pretty extensive rolling acne scars. He was actually a dermatology resident when I did his procedure in Salt Lake City. And you can definitely see the improvement we were able to achieve in just his skin topography and the surface texture. Of course, at this point, he does have post-inflammatory erythema. And so this is where I explain to the patients, you have to maximize your sun protection, because if you don't, you will hyperpigment. So, of course, he started to let his beard grow out while he was healing, but he did very well. This is, again, an example of him. I think this was maybe 2 months out from his procedure, but you can see that we did get great improvement in his acne scars. I did use the 1064 nano and picosecond technology on his skin type, and he was very happy with his results. And all of his residents came over to watch the procedure. It was actually like a fun Friday evening at the end of clinic that we did his procedure. This is another example of a Fitzpatrick 3 skin type patient. This was with fractionated CO2 laser therapy. She is 3 months out from her procedure. She had the full Monty with the subcision, the chemical peel, and the laser resurfacing, and she did well. And then here's another example of a Fitzpatrick skin type 4 patient. Again, pretty extensive scarring with rolling acne scars, where the combined subcision with your laser really gives you a lot of bang for your buck. You can see he still has a little bit of scarring on his temples, but he's definitely improved from where he was. And so again, setting those expectations, I always tell patients, I can at least ensure them that they are going to have improvement. I never really tried to give them a full percentage, because if I tell them 80% improvement, my 80% is different from their 80%. So I try not to get into those, and I try not to tread into those waters where the patients are going to hold on to every word you say, because you have to really think about how much this has affected their quality of life, how much it's affected, just their social interactions. So they really are coming to you for something that's going to be a game changer. But again, setting those realistic expectations and not giving them a promise that you can't deliver is going to be of utmost importance. The most common complications that I tend to see are going to be either post-inflammatory hyperpigmentation or erythema. I always counsel patients about erythema, especially because of the laser energies we are using. I tell them it's going to be from 2 weeks to 2 months, depending on how their skin likes to heal. And so I just tell them that we want to definitely maximize their sun protection. Infections are another one. So for my patients who may not follow the protocol, which will definitely include a lot of, healing ointments on their face for the first week, infections are extremely high. This particular patient, who was my medical resident, he got on the plane the very next day to fly to California so he could heal at home. He got a horrible infection. I'll definitely see if I can email that out if you guys want to see the picture. I forgot to add it, but he had a horrible infection over his forehead. We were all pretty nervous that he was going to scar, but he did extremely well. But we told him not to get on the plane, but he did. And so again, I don't know why you would get on the plane when your face looks like how it does post-op day 1, but you try to, counsel the patients as best you can. And then of course, thermal burns, or possible scarring. And so that's where, if I'm really nervous about a patient, I will definitely test spot. And so again, another takeaway from the lecture is test spot, test spot. You can never test spot enough. And if you explain to the patient, I'm going to test spot you until we both feel extremely comfortable, they will always thank you. I have one particular patient right now. She has a cafe au lait macule on her cheek. She's a Vietnamese young lady. She's beautiful. She wanted lasered off. And so I've already had to talk to her about exactly what it is and what might, possibly work. But I've been test spotting her for the last 9 months. And every time I use a different setting, I've used different lasers, but she always comes back with this erythema that I explained to her. If you have this on your cheek, you will be upset. And I would be upset. So again, she comes in and we test spot, we talk about it. I've sent her to other colleagues just because I'm like, I think we need to have another opinion. She still comes back to me. I'm still kind of working out if I'm going to actually treat her fully with Dr. Taylor. I still call him all the time, but you can never test spot enough. Things to remember with your considerations are definitely going to be the different wavelengths with skin of color. Hair removal, I love sticking with 1064. When it comes to benign epidermal lesions, I think your hypercator energy, which is not a laser, or possibly considering something that's going to really just vaporize an epidermis, which is your erbium YAG laser, is going to be great. Just again, remembering those treatment parameters and test spotting. I can't explain to you enough SPF is key. You know, no dermatologist is going to talk to you about SPF, no matter what the lecture is. And then again, just thinking about pre and post-treatment lightening agents. I tend to post-treat more than pre-treat, but no one will fault me for pre-treating. And then, of course, your epidermal cooling is going to be of extreme importance. So you may have seen in some of my pictures, we do some cooling with contact from the laser itself because it may have like a cooling tip on it. When I'm doing more aggressive laser therapies, as you can see in this picture, this patient already has sterile woven gauze over this cheek. I have sprayed this down with chilled ice water. So whenever I'm doing some fractional ablative resurfacing, I am always putting chilled ice towels or woven gauze over the patient's skin immediately after, so I can calm down all of that thermal energy that's just been delivered to the skin. Again, lasers are safe and effective in skin of color. Test spots are going to be essential, definitely setting those expectations. And then also your pre and post-treatment guidelines are going to be of utmost importance to minimize your side effects and complications. I hope you all have enjoyed the talk, and I think I may have some time for questions.
Thank you, Dr. Davis. My name's Sonali. I'm one of the PGY2s at OU.
Yes.
I am going to read a couple of the questions from the question box.
Okay.
So from Etisha Jefferson, we have a question. Oh, first of all, thank you so much for your talk. We're learning so much with you. Thank you.
You're welcome.
She said, how do you manage the care of women with endoderm issues such as PCOS? And they come into clinic with hyperpigmentation on their cheekbones or hirsutism. Do you work alongside their endocrinologist to ensure their PCOS and hormonal levels are controlled before seeking laser treatment?
I do, and that's a really good question. And I like that you even brought up the endocrinologist. Usually if I see patients with PCOS or hirsutism, I'll usually start to ask them, you know, what has their formal workup been up to that point? Have they had, you know, blood work done? You know, are their hormonal levels being managed, and what treatments are they on? If they're not, I do feel comfortable definitely ordering the lab workup for PCOS. However, if at that point they don't have an OBGYN and an endocrinologist, then I'm usually plugging them in. And I will usually say, sometimes I will order the lab work ahead of time and make sure that I connect them with one of my colleagues. Sometimes I will refer them to OBGYN or to obstetrics and gynecology and an endocrinologist who can then order the lab work, because sometimes there may even be some more testing that they want to do. But I want to make sure that we've evaluated their hormonal levels to see if there are any medications that are going to be warranted for their diagnosis. We start them on, whether that's going to be spironolactone or metformin or some of the other ones. I still also like to make sure that my patients are on just a good basic skincare routine. So again, a gentle cleanser and moisturizer, of course, sunscreen, absolutely. And I do love a topical retinoid. I mean, I think that they're just great to overall improve the texture of their skin, but slowly start to minimize some of that post-inflammatory hyperpigmentation. Then if there is any hyperpigmentation left, you know, if it's more just a discoloration, I may start with chemical peels before moving to lasers. But if we also have, again, that hirsutism component with ingrown hairs, then I will definitely talk to them about laser hair removal. I try to quickly move them from waxing, threading, or whatever, because they're just going to keep spending money. And I just tell them it's the best investment you can make, and it will give them the most bang for their buck. But great question. But I do like to have endocrine and OB-GYN on board, because I know what I know. But if there's some certain lab values and they come back and they're extremely elevated or extremely low, I am not necessarily the person you want replacing your hormones. And I know to stay in my lane.
Right. Thank you. One more question from Dr. McLaughlin. What is or are your maximum sun protection products that you like to use for your patients that you recommend?
Great question. So I love physical sunscreens. And let me tell you, I will tell you, especially when it comes to skin of color, whatever sunscreen they're going to use every day is the best. Okay. So if they have their favorite sunscreen and they're already compliant with it, then it's already a win-win. I do personally love physical sunscreens more than the chemical ones, just because, again, it's going to block those UV rays. One of my favorite ones that I'm loving right now is Isden. I hope it's okay. I don't have any relationship with the company at all, but Isden, they have one. It's called the Isden Aerofotona Ageless. It's a tinted sunscreen. It's actually mattifying. And I just find, like, at least for me personally, I'm extremely oily. So I love a mattifying look, but it tends to blend in with almost every skin type, even to your Fitzpatrick 6. My second favorite physical sunblock is by Tizo 3. It's a sunscreen primer in one. For those of you who follow me on social media at Dr. DiAnne Davis, I literally just posted both of those in one of my recent posts. For Melanoma Monday. That's my second one. And I think Isden has an SPF of 50. I believe Tizo is an SPF of 40. Just a couple of other sunscreens that I can tell you are favorable for patients with skin of color would be the Supergoop Unseen. It's an SPF 40. It's also on my recent post. It's completely clear, so it goes on flawless. Also, Melee, which is a company under Unilever, they have one called Do the Most, DEW, the most. That is a chemical sunscreen. It comes out clear, but it literally goes onto the skin. I mean, it comes out white, but it goes onto the skin flawlessly. So that's another one of mine that I do like to recommend for patients with skin of color. But if they come in and they already have a favorite, then it's already a win-win. But if they don't, then I definitely have a list that I have typed up of like my top 8 favorite sunscreens, and then I let them go and choose which one they like best. Oh, and someone, oh yeah, Supergoop Unseen. Okay, yes, we put it in the chat. Great.
Yes,
I'll put some more in the chat as well.
There are a couple more questions. So one of them is, how long after a course of isotretinoin do you typically wait before doing scar reduction procedures?
I do not wait. Well, okay, let me take that back. It depends. So if they are coming in and again, their primary process is acne and they have, nodular cystic acne, then of course I'm definitely doing a course of oral isotretinoin, definitely for about 6 months. And then I tend to slowly taper my patients off. So I kind of explain to them, we may be on it for a total of 9 months, but I don't like to stop cold turkey. So again, I always want to calm down the acne first. So I would say anywhere from about 5 to 7 months. After that point, I feel comfortable doing almost any procedure, with the exception of fully ablative CO2 resurfacing. There was a consensus paper that came out from the American Academy of Dermatology where it used to be thought that if they're on isotretinoin, you could not do aggressive procedures. But now the consensus from a lot of the experts in the field is that you can, with the exception of fully ablative CO2 resurfacing. If they're coming to me and they pretty much their acne is for the most part under control, but again, they have super oily skin. For men, I will put them on isotretinoin 2 weeks before their procedure. I will fully do the full laser surgery protocol, and then I will usually keep them on it for about 2 weeks to maybe 3 weeks post-procedure. And then depending on, if they like it, and it's also minimizing those little few breakouts, I'll keep them on it or we slowly taper them off. For my women, of course, I have to follow the, protocol when starting oral isotretinoin. So I will usually have to, again, have those 2 negative pregnancy tests, and then I will start them on it. And then I'll usually, once I get them started on it, though, 2 weeks later, I will definitely do the procedure.
Thank you. I think we have time for another question. So it says, is it possible to use lasers? Oh, we just covered that. The full Monty of acne scars seems expensive. For patients on a budget, besides encouraging topicals, what procedure do you think is the most cost effective for a patient on a budget?
I would say, especially when it comes to skin of color, chemical peels are a great procedure. It's great on the pocketbook for the patient. It's also great on your cost of supplies as a physician. Because for the most part, there's going to be some level of discoloration with acne scars. And again, for skin of color, what we, identify as beauty in our field is going to be a nice, even complexion. So I think chemical peels can definitely take you, they can give you a lot of bang for your buck, minimal downtime. I mean, there is some, but some minimal downtime, and it doesn't have a lot of fuss. And oftentimes, like a 10% TCA chemical peel in my practice will range between $300 to $500. Someone typed in a question, does insurance cover any of this? For the most part, no, these are considered cosmetic treatments. I will tell you for the full acne surgery with the subcision, the laser resurfacing, and also the chemical peel, that usually will start off at about $3,500, but then the price can, kind of be a little bit less or more depending on if we add on any other treatments. Most patients that I see actually will tell you that for the most deal, especially if they've already come to you and they've usually probably spent $8,000 on RF microneedling, or they spent, on all of these other treatments. I mean, I see patients who come in who have spent tons of money. So I do think it's still, a pretty good deal. But again, the most cost-effective thing that you can start with would either be chemical peels or microneedling. Microneedling is also a very mild treatment that you can do that doesn't cost a lot to help treat acne scars, but it will definitely depend on the severity of the acne scars.
Great. I think we are about done, but thank you so much for your laser talk. Everyone learned so much, and we have about a 10-minute break right now. So Dr. Allen.
Thank you, Dr. Davis. I tell you, you never disappoint.
Thank you. Thank you. It's so happy to be back with you all.
Yes, and so good to see you. You've taught us so much today, so thank you.